Over the years, one of the more debated topics in the urology arena includes the relationship between testosterone and prostate cancer. Many men are curious if testosterone could be putting them at higher risk for developing prostate cancer. Can men go back on testosterone therapy after being treated for prostate cancer? And how can manipulating your testosterone level be used in the management of more advanced prostate cancer cases? Well, stick around because we have international prostate cancer expert Dr. Jud Mal from Duke University joining us today to get you up to speed. So the big question is this: how can men and those who care for them better educate themselves regarding prostate health, the conditions that affect the prostate, and the latest technology in managing these conditions? That is the question, and this podcast will provide the answers. On a weekly basis, we will be chatting with experts, innovators, and leaders in the field of urology, sharing useful information with the general public to improve their lives and increase their overall health. My name is Dr. Garrett Pullman, and welcome to the Prostate Health Podcast. Prostate Health Podcast is for informational purposes only. Nothing in this podcast should be construed as medical advice. By listening to the podcast, no physician-patient relationship has been formed. For more information and counseling, you must contact your personal physician or urologist with questions about your unique situation. I'm very excited to have Dr. Jud Mal making a second appearance back on the Prostate Health Podcast. Dr. Mal helped us kick off the initial launch of the podcast as a guest for episode number 2, one of our most popular episodes to date covering prostate-specific antigen, a man's check engine light. Now, for our listeners who have not yet met Dr. Mal, he is an expert when it comes to prostate cancer. He joined the Duke faculty in 2004 after a career in the U.S. Army Medical Corps, mainly at Walter Reed Army Medical Center. He is a retired colonel and noted researcher and clinician in the area of prostate cancer. He has authored and co-authored more than 275 scientific manuscripts and book chapters. He served as the editor for Prostate Cancer and Prostatic Disease Journal, and is a popular speaker and lecturer, having been visiting professor and keynote speaker throughout the U.S. and the world. Dr. Mal, welcome back to the Prostate Health Podcast.
Thank you very much. It's really an honor and pleasure to be back.
Well, over the years, there's certainly been a lot of debate when it comes to the discussion of testosterone and prostate cancer. And I'm sure we'll be getting into that here today. But before we do, I think it would be helpful for our listeners to first take a look back in time. So when did we first become aware of any relationship between testosterone and prostate cancer?
So that's a great question. And we've known about this relationship since the early 1940s. Huggins and Hodges, who were certainly well known to us in the urology field, were the two physicians who discovered that link in the early 1940s. In fact, they shared the Nobel Prize in 1966 for that discovery. And early on, they found that, well, in those days, the option was to remove the testicles. And when they removed the testicles, which is called an orchiectomy, patients who had metastatic prostate cancer got better. Their disease disappeared for the most part, and the clinical symptoms went away, and they did well. They then experimented with doing actually adrenalectomies in some cases to see if that extra boost of getting rid of the adrenal androgens would help the situation. And when I came into the urology field in the mid to late 1980s, we just started to have the luteinizing hormone releasing agonists, that what we affectionately term now as Lupron, which is basically one of the agents, and that replaced orchiectomy. That was medical castration, or the ability of a medication to lower the testosterone level, similar to that of removal of the testicles.
So, and since then, how has treatment evolved in manipulating the hormone levels for men with advanced prostate cancer? You kind of mentioned, switching over to more of a medical hormonal therapy, such as you said, the Lupron or the LHRH agonist. So how do these actually work in reducing that testosterone level?
So the injections, the hormone, what I call hormone shots, actually work in the brain to tell the pituitary gland to shut off the production of subhormones, if you will, to the testicles, and then the testicles decrease their production of testosterone. And so that's why it's called medical castration or medical hormone therapy, because these medicines are turning off the production of testosterone and testosterone metabolites. Now, in fact, that's, again, called medical castration. And then that was used, again, either orchiectomy to remove the testicles. Orchiectomy was used from the 1940s through the 1980s as the main way. Then in the 1980s, the hormone injections came to play. And for patients, I like to refer to it as anti-fertilizer therapy. I'm sure you've done the same thing in practice, that the testosterone is the fertilizer that makes the prostate cancer grow. And so by eliminating the fertilizer or eliminating the testosterone, patients understand then that that's the way we're going to get their prostate cancer to evaporate and shrink away, and so that they feel better. In the late 1980s, in fact, in 1989, the first oral hormone agent to supplement the shots came into being, and that drug was called flutamide, and that was what they call a non-steroidal oral anti-androgen, and that ushered in the era of what they call combined androgen blockade, which meant that we were shutting off the production of the testosterone from the testicles with the injections, the Lupron-like shots, but we were also giving the patient a pill, an oral medication, to block some additional testosterone that was produced by the adrenal glands. And then that was in play for about 20, 30 years. So we had flutamide as an oral agent, then we had nilutamide as an oral agent, and then we had bicalutamide as an oral agent. And those three pills formed the basis of combined androgen blockade over the period of the late 80s through about 10 years ago.
So for men with prostate cancer, who is a candidate for androgen deprivation therapy or this hormonal therapy?
That's a great question. Classically, it was men with metastatic or spread prostate cancer. And in fact, the hormone therapy was the basis for all treatment of advanced prostate cancer, and it still is. Now, in the last 20 or so years, we've also learned that hormonal therapy can help men with other earlier stages of prostate cancer. For example, when men receive radiation treatments for prostate cancer, hormonal therapy, for the most part, is part of that treatment. And for men who have middle of the road prostate cancer or high-risk prostate cancer, they will use varying durations of these hormone shots and hormone pills possibly to treat those men in conjunction or along with the radiation therapy.
So for these men that are being treated with this hormonal therapy, what testosterone level are you shooting for?
That's a great question. And the number to lower the testosterone has varied some over the years. Still today, with the Food and Drug Administration on approval of these agents, the benchmark is getting a testosterone level to 50 or less. And that is the traditional definition of castrate levels of testosterone, meaning if you remove that man's testicles and did a blood test to measure his testosterone level, you would expect the testosterone to get to 50 or less, and then that became the benchmark for the injection. So the injections were FDA approved based on at least getting to the level that would be achieved with removal of the testicle. However, more recently, people felt that 50 may be still too high. And so many experts in the field, if they really want to treat a man with prostate cancer properly, they will aim to get the testosterone level less than 20.
So what are some of the potential side effects one may expect or be aware of when on hormonal therapy?
Well, I'm sure you do the same thing in your practice, but I always talk to the patients about the hormone therapy being a double-edged sword, that no question that hormonal therapy for a gentleman with advanced prostate cancer can make immediate benefit. And so classic example is a guy coming in to, say, the emergency room, has back pain, has symptoms, and sadly, he has metastatic or advanced prostate cancer. You do hormonal therapy, and he may be literally better in 72 hours. And it's almost like the story from the Bible, I guess, with Lazarus, risen from the dead, that you can take a patient who's really severe pain with prostate cancer and you give him a Lupron shot or remove his testicles, and he goes from being bedridden to walking around asymptomatic within a day or two. It's sometimes dramatic.
Yeah.
And all of us who are urologists have seen this in our careers, and it's so impressive. Now, that's the good news. And many times that effect can last for years, or at least several years, until the effect wears off or till the body becomes resistant to that hormone treatment. But the downside of this hormone treatment, if it's used, say, for longer than 6 months or a year or longer periods of time, men will have side effects from low testosterone, such as osteoporosis, which means they have bone mineral loss from their skeletal system, which can cause symptoms. They can have hot flashes. They can have weight gain. They can have decreased energy level and decreased energy in their muscles. And in long-term use, if a guy has to stay on hormone therapy for a couple of years or lifelong, it can increase the gentleman's risk of diabetes and increase the gentleman's risk of heart disease. So again, a real double-edged sword.
So can prostate cancer ultimately become resistant to this testosterone suppression?
Sadly, it usually does. Classic studies suggested that about 90% of men eventually would become resistant to hormonal therapy. And the worse the disease is at the beginning, the shorter the effect of hormone therapy. So, for example, if a patient presents with widely metastatic prostate cancer, his initial response to hormonal therapy may be only a year or two. However, if you use hormonal therapy in earlier stages of disease, or even in men who have a rising PSA after they've had surgery or radiation, the benefit of hormonal therapy can last for a decade or more.
Mm-hmm.
Some of the old school urologists or old school experts used to say that 10% of men who had metastatic prostate cancer were cured by hormonal therapy, which may be a strong term, but what that meant is they went on hormonal therapy and there were amazing responders and their disease stayed quiet and low amounts of cancer in their system for up to a decade.
So, and I know this next question, I mean, we could probably cover an entire episode on this, but I just thought we'd just briefly cover it. Now, what, for those men that, start having a rising PSA or, signs of resistance to the therapy, what options do these men have now?
So let's set the stage a little bit further. So this would be a gentleman who was on hormonal therapy and then his PSA starts to rise a bit, correct?
Correct. Yep.
So first off, the urologist or the medical oncologist or the radiation oncologist needs to determine if the patient's on continuous hormone therapy, meaning if the gentleman is having the shots and the pills regularly, or at least the shots, the hormone injections, and the PSA is going up despite him being on this continuous hormone shot, then that's called early castrate-resistant prostate cancer, or what we refer to as CRPC, and that has two varieties. One is non-metastatic CRPC, and the other is metastatic CRPC. Non-metastatic CRPC would come into play when a patient went on hormonal therapy for only a rising PSA, say after surgery or radiation. Metastatic CRPC would come into play when the patient had metastasis at the beginning or developed metastasis already and then went on hormonal therapy. I know for patients it's a little bit complex, but these are all categories or states of prostate cancer that the prostate cancer doctors team uses to figure out, how to manage those patients.
That's the thing with, nobody wants, prostate cancer, but it seems like over the last 10 years, we've kind of really had an explosion of, options now for these men and, in helping them, which I think is, which we didn't have before.
Just to follow up on your question about treatment, earlier on we were talking about flutamide, nilutamide, and bicalutamide. Those were the drugs from the late 80s through the 90s, which were these non-steroidal oral anti-androgen hormone pills that were added to the injections. What we learned is those were quite weak. They were beneficial, but those agents were fairly weak in their effectiveness or their potency. And so about now close to 7 or 8, 9 years ago, they developed, the pharmaceutical industry working with academic centers developed more potent pills, more potent non-steroidal oral anti-androgens, and those are considered third generation non-steroidal oral anti-androgens. The first one on the market was a drug called enzalutamide. Then we had apalutamide, and now the third agent is darolutamide. And these are all sound very similar to flutamide, nalutamide, and bicalutamide because they're in the same general drug class. They're just more modern pills and more potent, more effective pills. And interestingly, those 3 pills now added to the hormone shots really show a big-time survival benefit in these patients with early castrate-resistant prostate cancer.
Now, one of the common questions I get, when we get to that point where we're talking about, some of these additional therapies is, do I need to stay on my hormonal therapy?
Well, it depends on the degree of disease. Sometimes men have earlier amounts of metastatic prostate cancer or lower volume advanced prostate cancer where we can use the hormone therapies intermittently, use them for a while and then discontinue them, give the patient a drug holiday, give them a period of time and then restart it. But for other men, once they develop castrate-resistant prostate cancer, the data seems to suggest that the hormone therapy should be continuous and should be just used, every day and not give the patients a break.
Well, I know that can get very complex, and I really appreciate you kind of breaking that down into a kind of understandable fashion for our listeners. So now, low testosterone level, or what we call hypogonadism in men, is quite common, and many men meet criteria for treatment with supplemental testosterone therapy. One of the concerns in the past in prescribing supplemental testosterone therapy for men with low levels has been the reported link between increasing hormone levels and prostate cancer. So should men with no prior history of prostate cancer be concerned that taking testosterone supplementation could put them at higher risk of developing prostate cancer?
That's a great question and a very fundamental question. And most current experts would suggest that testosterone supplements do not increase the risk of developing prostate cancer, which seems weird because here we have guys who have prostate cancer and we take the testosterone away and the cancer gets better. But it seems that men who do not have prostate cancer and who have been screened and do not have an elevated PSA or concern for prostate cancer can safely go on testosterone supplements and not have a higher risk of developing prostate cancer. Now, there's a couple caveats though, is we just don't want to willy-nilly treat all men with testosterone supplements. And there's a risk of abuse because some men want to be supermen, some would want to abuse testosterone to build muscles or to increase their sexual stamina and so forth. So in the urologic field, we want to practice ethical medicine. And so the only men that we really should be recommending testosterone supplements for are men who have documented what they call hypogonadism. In other words, documented low testosterone levels. And that's generally done by measuring testosterone 3 times at least over a month period of time. In the mornings, mid-morning, testosterone levels are considered the best. And sometimes you would even do what they call a free testosterone along with the total testosterone. But the key teaching point is the patients who should be treated are the patients who have documented, medically confirmed low testosterone levels or medically confirmed hypogonadism.
Well, thanks for kind of addressing that. So lastly, it's been common practice to go ahead and stop a man's testosterone therapy at the time of prostate cancer diagnosis. That's if he was already taking supplemental testosterone for those men that have hypogonadism prior to the diagnosis. Testosterone replacement then after definitive treatment such as surgery or radiation for prostate cancer has been a debated topic. And where do you think we currently stand in terms of when it might be safe to go ahead and restart testosterone supplementation following this, definitive treatment for prostate cancer?
Well, I'll be the first to admit, I'm not a world expert in this area. I'm a practicing urologist. I treat a lot of men with prostate cancer and I have quite a few men who have low testosterone levels. I've learned the most from a urologist who's in Boston in the Harvard system named Abraham Morgentaler. And I believe that Dr. Morgentaler has probably done more work in this area than anybody in our urologic field. And his concepts and research has suggested that, here's the way I understand it, it's kind of better for a man to have a normal testosterone. You don't want a hyper high testosterone and you don't want to be hyper low or low testosterone. You want that normal physiologic level of testosterone in your system. And even if you have prostate cancer, having a normal testosterone is better than a very low testosterone. And he's done even studies in men on active surveillance, meaning men that we know have low volume or small amounts of prostate cancer in their body, and they're being managed with a monitoring strategy. And he feels that those men, if they have documented hypogonadism, if they have documented low T, they're better off having testosterone supplementation to keep their testosterone levels in the normal range. Again, the caveat, though, is you don't want to crank those levels up really high. And so those men are going to require monitoring with periodic testosterone levels, and they are going to possibly require some adjustments to their dose if you want to do this properly in a sound medical fashion. And the reason I mention that is there are clinics out there that are probably not very scrupulous that will give any man testosterone if he pays for it. And that's a challenge too, because if a gentleman has a normal testosterone, and let's say he does it right, where he has 3 normal testosterones over a month, his free testosterone is in the normal range, but he says, well, doc, I just feel tired. I really just want to have more testosterone. I want to be a man's man or be a manly man. That's probably not a good idea. And those are the gentlemen where you crank that testosterone up to too high, to super physiologic levels, where then I believe you can get into problems with BPH, you can get into problems potentially contributing to prostate cancer, elevating their PSA, and even causing problems because their blood count gets too high. That's another big issue, is if you crank the testosterone too high, patients, their hemoglobin and hematocrit will go too high, and then that can lead to strokes and all kinds of bad stuff. So it's not if you're going to do testosterone replacement, a patient needs to have a doctor who is ethical and is trying to do it the proper way and not just giving him high doses of testosterone.
Well, Dr. Mal, I think all of this has been wonderful information today for our listeners. As we wrap up the podcast today, any parting words of advice for our listeners out there?
Well, I would say that, for men or family members who have prostate cancer, have advanced prostate cancer, find a urologist who is very comfortable managing prostate cancer. Many times urologists will work on a multidisciplinary team with a medical oncologist and a radiation oncologist, particularly as they manage more advanced prostate cancer. And that's always very generally quite good care. I would also say that if a gentleman feels that his testosterone level may be low and he has symptoms of low testosterone, he should see his urologist or his primary care physician and have his testosterone level measured. But just be careful that you would not want to treat with testosterone if the gentleman has a normal testosterone, because then that could lead to abuse or overtreatment and more side effects.
Well, we really appreciate you taking time to come back to join us for a second appearance on the Prostate Health Podcast. You again have given our listeners a lot of valuable information to help empower them as they learn more about their prostate health. Thank you again.
Thank you very much. It's always a pleasure and honor, and you do a great job with this series. Thank you so much.
Yeah, thank you.
Thank you again for listening to the Prostate Health Podcast. We would love to have you join our podcast Facebook group at www.facebook.com/groups/prostate Facebook.com/Prostate Health Podcast, or just use the Facebook group search function and search for the Prostate Health Podcast and ask to join. We'll see you at the next episode.